I'm Mike Gibson and Ajay Kirtane coming to you live from SCAI 2015 here in San Diego. Ajay, great session tomorrow on clinical trials to clinical practice. A lot of controversial studies out there. Hit some of the high points of controversy for tomorrow.
Definitely. This is a session actually that Roxana Moran and I had been doing for the past couple of years. And last year it was amazing for a clinical trial session where you talk about the evidence and that sort of thing, to have it packed and out the door. I think just shows you the type of audiences here at SCAI. They sort of want answers to help them with their clinical practice.
Right.
And kind of unlike a lot of the didactic lectures that you hear on these topics, even the rebuttals that are structured and formulaic in some respects, this is just 5 minutes max per presenter, and then open discussion and trying to bring it to the clinician.
A great format, minimize the didactic stuff. No more recitation of the facts. Let's digest it, let's argue about it.
I mean, we can all see the slides online. In fact, through you, we were able to see so many of these slides online, but people want to take that home and figure out how to treat their patients. But you need to do it in a systematic way. You can't just say, this is what I like to do. Let's look at the evidence for each of these 4 trials.
That sounds like CAF conference around the country. The way I like to do it.
Yeah. So this way, at least you look at it. We'll talk about clinical trial
Moving
issues
to the reason I like to do it.
That's right.
Away from the way I like to do it.
Yeah. So we'll see. And I mean, so we'll start off with DAPT.
Yes.
DAPT, as you know, trial looking at duration of antiplatelet therapy beyond 12 months. And I think this is really important because the guidelines committees are going to be struggling with this. A lot of clinicians are struggling with this. And it's interesting because it's a study that was done predominantly after 2006. So it's somewhat dated, but yet still contemporary stents in the study.
But there's no date, doesn't matter when you did the study, 54% of the events are in the non-target lesion.
That's right. No, that's absolutely right. But there's controversy because after it came out, there have been some meta-analyses really looking at this issue of the mortality issue in this trial, that mortality was higher with extended duration DAPT. Is that a real phenomenon? Is it an epiphenomenon? So all these things I think will come out and hopefully give some answers to the clinicians. Beyond that, we'll look at total thrombectomy trial. You and I have been talking about this for a long time. Should we do it in everybody? Should we do it in some patients? How do you put in not only this trial but the other trials that have come before it in context for guys who are going to go home and do their cases?
Well, when we debated about this a few weeks ago, we said, well, probably not a big role except for refractory thrombus, et cetera. So then a week later after that, I was in the cath lab. I had a left main thrombus and a guy with a STEMI, and we just said, well, there's probably not. I went ahead and still did aspiration, No,
and there's clearly a role for it. It's just the question, is it routine? And how do you sort of put together these trials that have been largely negative with others' experiences and to figure out how we treat patients?
The trial is negative, but there may be some sweet spots, right?
Yeah. And so then beyond that, we'll talk about bivalirudin.
Yes.
This is something for interventionalists here in the United States.
It's almost a full-time hobby or profession debating about bivalirudin.
It was really interesting. I had a conversation with somebody who basically compared this now to, it's like debating politics, where you got the Democrats, you got the Republicans, and really people don't want to talk about it. But we're going to talk about it.
We're going to talk about it
anyway. And just, in light of the more recent data from Matrix and putting everything together, how clinicians ought to think about their anticoagulants in the cath lab. And then finally, probably something that's not so controversial, but we'll make it be, and that's the latest studies on TAVR. And I think the controversy there starts getting at what point should we start saying, well, who shouldn't get a TAVR? When you have outcomes that are so comparable to surgery, and when you have surgical devices where, frankly, the durability of the newer valves hasn't been tested that long. As they iterate valves, they don't test them for 15-year follow-up. And so if it were you or me or my dad or your dad, I mean, at some point and somebody says surgery, is that something you'd want? Or do you think we should be doing TAVR in lower risk patients? And how do you put the trials and the data we have to date in context that way?
Well, great format. I'm a big fan of the shorter sessions the shorter talks, the shorter didactic portions. Even at ACC and TCT, everywhere has gone from 12 minutes down to 10 minutes. Seems like they're drifting towards 8 minutes, which I think is good.
Yeah, and I think as
expanding the time for discussion is the right thing.
That's the key thing. I mean, when people come to meetings, they come for the interaction. And some of the other things you can get online or otherwise. I think the other thing, that Dave Cox, who's participating in the session, emailed us a bunch over the weekend, and I saw him today, and he said it's actually harder to do a 5-minute talk than it is to do a 15-minute talk, because we're so reliant upon our slides that when you have to sort of think about what's important and how I'm going to say it in a cohesive way, that's tough.
But if you're thinking about it, if you're communicating to a colleague about a patient, you don't give a 15-minute presentation. You give a 3 to 5 minute.
Some of us do. No,
I hope not. But see, it's not useful.
Yeah.
The useful information you have to convey. But the real benefit of SCAI is the debate and giving everyone a chance to get up to the microphone and argue and ask the questions.
And I know you're involved in education a lot. I think even when you look at grand rounds formats and that sort of thing, the most effective speakers that I've had are those that present cases and then some data and then some clinical relevance and then some basic science and weave it together in that kind of way. And we're not talking about a single long lecture here, but for those types of things, for the clinician, you want to get a bunch of different areas and to think about a lot of new things, and that's what we're trying to do.
Well, debating is what we all do best, I think, as interventional cardiologists, and I think it's that kind of scrutiny of the results has really driven, I think, interventional cardiology and cardiology in general forward.
Yeah, so we'll see, and I think it'll be well received again. We're excited for it. I got to read up tonight, so I'm on my game, and we'll go from there.
Good. All right. Thanks for coming by, Ajay.
Thanks, Mike.
Thanks to all of you for joining us here live from SCAI 2015.